Good afternoon, dear colleagues, honorable panelists. It's a pleasure for me to be here today with you and to present complication of the access in TAVI and TEVARs. Unfortunately, I have nothing to declare, and since the beginning of using of TEVAR and TAVI procedures, they're going straight up with the number of the patients worldwide. As you can see, even the peak of the number of patients isn't still visible. The numbers are still going up. Even actually, it's getting even higher. The count of the patient in TAVI procedure after 2017, when the indications for low-risk patients were approved. I can't express my gratitude to Professor Trendafilova and Professor Petrov that they helped me a lot with the access topics. But for all of the registry, as you can see at the bottom, the femoral artery access is the more favorite one. According to the definition, contemporary Valve Academic Research Consortium 2. If I'm wrong, please correct me. There is a Consortium 3 that appeared in April of this year, but I'm still using 2, the second criteria, because all of the trials and the studies that I'm going to show you, they're using the same criteria for describing the access complications. The dissections, stenosis, perforation, rupture of fistula, pseudoaneurysm, hematoma. The major vascular complications are any aortic dissection, aortic rupture, annulus rupture, left ventricle perforation, or a new apical aneurysm, pseudoaneurysm, or access site, access-related vascular injury, hematoma that are leading to death, life-threatening or major bleeding, visceral ischemia, or neurological impairment, or distal embolization from a vascular source requiring surgery, or the use of unplanned endovascular or surgical intervention, or any ipsilateral lower extremity ischemia documented by patient symptoms, or surgery for access site-related nerve injury. Minor vascular complications, they include access site or access-related vascular injury, not leading to death, life-threatening or major bleeding, visceral ischemia or neurological impairment, or distal embolization, treatment, or embolectomy, thrombectomy, and not resulting in irreversible organ damage, or any unplanned vascular stenting or unplanned surgical intervention, vascular repair or the need of vascular repair, percutaneous closure device failure of the closure device to achieve hemostasis at the arteriotomy site leading to alternative treatment. Bleeding classification is classified in 3 groups: life-threatening fatal bleeding that causing hypovolemic shock or severe hypertension requiring vasopressors, surgery, and overall bleeding, hemoglobin drop more than 5 grams per deciliter or transfusion more than 4 units. Major bleeding associated with drop of hemoglobin at least 3 grams per deciliter or requiring transfusion of 2 or 3 units of erythrocytes, or minor bleeding that's defined as bleeding worthy of mention but does not include any other of the categories. Access site complication epidemiology, WIN-TAVI study, VARC major complications accounted 7.0 for bleeding complication, and VARC life-threatening accounted 4.4. In partners, 70% of the patients undergoing TAVI had vascular complication, and 9.3% had a major bleed. In partner 2, 7.9% of the patients received a TAVI had major vascular complication, and 10.4 had life-threatening or disability bleeding. From great registry, there were reported common femoral artery access have ranged for 1.5 to 7% complication. In partner trial, access site hematoma counted 23% of the major complication, pseudoaneurysm 3.4%, and access site dissection 6.5%. In meta-analysis that includes 3,500 patients, incidence of major vascular complication was 11.9%, and major bleeding occurs in 15.6%. In another meta-analysis that includes 24 studies and 4,300 patients, we can see that the rate of major vascular complications are fewer in the new devices, with the new generation, with lower profile device, and the thing that matters is the experience of the team and the operators, and the risk of the patient. The intermediate risk patients have fewer major vascular complications. In study that's publicated last year, September, in Nature, from pooled data from 273 studies, over 68,000 patients, shows that Sapien 3 has the lowest rate of vascular complication comparing to Sapien XT, and post-interventional bleeding shows Evolut R valve better results than core valve. But it's not only it's not only on the point of vascular complication, but on pacemaker, bleeding, death, stroke, surgical replacement, and coronary obstructions. The next generation of devices show better results with the patient. But why should we bother if we have perfect implantation of the valve? There is no regurgitation. Yeah, there was some bleeding. The patient had to be transfused with 3 or 4 units of hemoglobin, of erythrocytes, but here is a couple of studies, as you can appreciate, that shows that the patient with vascular complication have typically worse 30-day and one year mortality than the patient without vascular complication. Risk factors for vascular complications for endovascular treatment of aortic stenosis and AAAs are female gender, center operator experience, sheath to femoral arterial ratio less than 0.5, moderate to severe vascular calcification, tortuosity, peripheral arterial disease, sheath size over 19 French, external sheath diameter more than minimum arterial diameter. That's a Portuguese trial that shows that CFAR, which is sheath to iliofemoral artery ratio, has highest sum of sensitivity and specificity for access site complication. How to achieve success? Accurate pre-procedural evaluation, perfect matching between commercially viable prosthesis and anatomical characteristic of patient, technical implantation skill of the TAVI team, and tailored choice of access option. This table is published in Journal of American Heart Association, where if we have high-risk patient with deep femoral arteries, high risk on vascular access patient with deep femoral arteries, femoral arterial wall calcification, peripheral vascular disease, sheath to femoral ratio under 1.05. The measures that we can take is using the ultra-stiff guidance, prefer transradial secondary access, and consider surgical cut down. Not every patient is suitable for transfemoral TAVI procedure. It depends on the tortuosity and the calcification on iliofemoral side and the aortic, as you can see. Ultrasound guidance has shown a very good result in reducing the incidence of vascular complication in TAVI procedure. Also, if the patient has good creatinine clearance, we can use angiography to find the best way, the best spot to puncture the artery. But what happens if we combine both of the methods? A J-tip coming from radial artery or from contralateral femoral approach guide wire placed in the reference of the ideofemoral artery, and with ultrasound imaging to identify the J-tip of the 0.03.5 inch guide wire, puncture that place. Another method that we have is the ultravascular lithotripsy. This technology has been tested in patients with calcified femoral-popliteal vascular lesions. In the disrupt path study, first and the second one, has really good results with only 1.5 wire-related dissection requiring stent placement. Indeed, these procedures, these studies are made in patients for coronary angiography, but I'm going to show in the next slide study for TAVI procedures with intravascular lithotripsy. Down you can appreciate a case with patient with really severe calcified peripheral arteries and the result after the procedure and after the TAVI. A prospective registry of intravascular lithotripsy shows 42 patients. The study used Sapient 3 valve, Evolut R and Evolut Pro with the size valve between 20 millimeters and 34 millimeters. And the results, as you can show here, there is 0 perforation, 0 flow limiting dissection, 0 provisional stenting, 1 pseudoaneurysm, and 1 endarterectomy. Access site closure method was transcatheter suture devices in 39 patients, which is 93% of the patient. Prevention of access of site complication, how we can achieve it with increasing operator experience, use of arteriotomy closure devices, surgical cut down, and crossover balloon occlusion technique, CBOT technique. Impact of routine crossover balloon occlusion technique. It's a study from Finland that shows the effect of CBOT technique using VARC2 criteria and shows reduction of the vascular complication 5.5% to 18.6% in the control group. The procedure is quite simple. From the control femoral approach, after the procedure is done, of valve implantation, guide wire is placed in the contralateral position. A suitable diameter balloon is inflated at the puncture site, and when the sheet is removed, the balloon is inflated. That reduces the blood loss and gives time the team to use the vascular closure device, and you can see the result at the end that there is no bleeding. Pave and crack technique is used also in TEVAR and TAVI procedures. You can appreciate the calcification of the arteries in the patient at the beginning of the procedure. After the implantation of the stent, we have really good result that helped us to continue with the implantation procedure. How to manage vascular complication. Optimal management of vascular complication relies on early recognition. Levels of experience in preparation of the implantation team plays critical role in management of major vascular complication. When we evaluate our patient, we must prepare all the necessary devices on the table or maximally close to it if the complication appears, so we can act, because iliofemoral rupture is potentially life-threatening condition. As you can appreciate on the first video, the bleeding of the iliofemoral segment actually is the iliac artery. The thing that actually this patient was expected to be really hard. We used surgery access to reduce the risk, but unfortunately the complication happened. Immediately we put balloon to reduce the blood flow to iliac artery, and we continued and to give time to our colleagues surgeons to do their work and stop the bleeding. Another option, as you can see on the third picture, is occlusion balloon in the abdominal aorta that can be inflated, and again with the same idea. Here you can appreciate retroperitoneal hematoma on the puncture, over the puncture side of the procedure. Iliofemoral dissection. Dissection of iliofemoral artery requires percutaneous or surgical intervention. Has been reported up to 10 to 7.4% of patients undergoing transfemoral TAVI procedure. Prolonged inflation of the balloon with appropriate diameter result in successful position of the anthema and underlying media. Pseudoaneurysms, we can use good old compression or ultrasound-guided compression, ultrasound-guided thrombin injection to reduce the size and to close the pseudoaneurysm. Artery avulsion. In patients with borderline iliofemoral arteries, the sheet can adhere directly into endothelium, and the operator feels resistant to the sheet withdraw, and sudden hemorrhage may occur. If avulsion is expected, occlusion balloon should be placed, and patient should be prepared for possible surgical repair or implantation of covered stent. Vascular closure device complications may be connected to malposition of device and device malfunction. As Professor Petrov said, the ProgWide devices can be, sometimes we can need to use more than 2 devices. Sometimes can get a little bit more. Here you can see malfunction of the closure device that was treated with covered stent implantation on the place of the perforation. This is a trial that's pretty fair on my opinion. Comparing MANTA and ProgWide closure devices, 151 patients divided in 2 groups, 76 for ProgWide, 75 for MANTA. 20 patients for each group was for training group, and 50 patients are for compare. You can see that there was no, according to the study, there was no difference in the trial group, but in the compare group, ProgWide has better results than the MANTA with 2% complication compared to 20%. Vascular complication associated with transapical access. The most frequent acute complications were bleeding from the apical puncture site and myocardial tears requiring further surgical repair. Local hypokinesia. Long-term complications include aneurysm formation, chronic pain caused by retraction, pleural dissection, and iliocostal nerve damage. Vascular complication associated with transaortic access. Right mini thoracotomy may lead to injury of the right internal mammary graft if it's there are rare complications with transaortic access include laceration of the right ventricle after right mini thoracotomy, pseudoaneurysm formation in the of the intercostal artery. Access site complication are Achilles heel of an endovascular procedure, potentially leading to severe bleeding, prolonged hospitalization, increased morbidity and mortality. Potential risk factors including female gender, size of the catheter, increased operator experience, and advanced age increase the risk of developing this complication. Combination between operator and implantation team expertise combined with the evolution of the implantation and closure devices holds the key to help the prevention of such complications. Thank you for your attention.
Thank you, Dr. Angelov. Are there any questions or comments from the audience? If you know, thank you, Dr. Angelov.